Welcome to the Health is Number One podcast here at healthisnumber1.com. I'm your host, local family physician, Dr. Craig Wax, and we're talking about prevention and herd immunity, especially with regard to COVID-19 or the SARS-CoV-2 virus. Our special guest with us today is Dr. Harvey Risch, who is an MD or medical doctor, who has a Ph.D. in mathematics of epidemics, which is supremely helpful, I think, in this context. He also does cancer epidemiology with his everyday, and he's at the Yale School of Public Health in Massachusetts. Welcome, Dr. Risch.
Pleasure to be with you.
Thank you for taking time out of your extra busy schedule these days. Can you tell us a little bit about your background and training and what it means to be what you do?
Well, after medical school, actually in the last year of medical school, we had a thesis requirement, and I loved working in the lab and doing research. And so after medical school, I ended up going to graduate school and doing research in mathematical and statistical modeling that was applied, in my case, to the modeling of infectious epidemic processes. And then I did a postdoctoral fellowship at the University of Washington and learned epidemiology and started applying the mathematical modeling that I had worked on to toxic shock syndrome, which was, it tells you when I was doing this, back in the early 1980s. After that, I published a couple of papers. After that, I moved to the University of Toronto, learned a lot of field work in epidemiology, carried out a lot of epidemiologic studies, and then in 1991 moved to Yale. And so over time, I mostly do cancer epidemiology studies, but a year or so ago, with the COVID epidemic starting, the state of Connecticut, the Connecticut Academy of Science and Engineering, of which I'm an elected member, carried out a review and created a committee to review the reopening plans of the state. And so I was nominated to be on that committee, and I started working on issues about how we could be able to reopen the state after its lockdown was planned to be ending. And what happened was I very quickly got involved in looking at treatment for COVID, and the strangest things were appearing in the literature. What was happening is we were seeing drugs that were being used in hospitalized patients, and then the recommendations in the papers and the media pickups from these papers were saying that they shouldn't be used in outpatients. And we knew even then that the COVID disease is actually at least two different diseases. It starts with a disease in otherwise healthy people that's a flu-like illness. You get a sore throat, a fever, a cough, runny nose, tiredness, muscle aches, and so on, that are much more typical of an early flu-like illness. And then in a fraction of those people, after about a week or so, it progresses into a much more severe pneumonia that becomes hospitalizable. And that florid pneumonia, when the immune system creates a whole bunch of debris in the lungs that makes it difficult to breathe, is the hospital disease. You can imagine that for that hospital acute florid pneumonia are going to be very different than the treatments for trying to suppress viral replication at the beginning of the illness. But astonishingly, these studies of various drugs that were being looked at in hospital patients were being inappropriately extrapolated to outpatients, and I couldn't understand for the life of me why this was being done. I thought at first, oh, well, this is just maybe some, sloppiness or something like that. And so I started reviewing all of the papers that had been available to that point on potential outpatient treatments. This included hydroxychloroquine and possibly remdesivir, which was in development at the time. And we didn't know whether that was going to be in hospital only or could be used in outpatients. And so I wrote a paper on this that was published May a year ago in the American Journal of Epidemiology, synthesizing all of the evidence to date, and it was just basically a plain vanilla review paper with nothing radical in it, just saying that you have to treat outpatient illness separate from hospital illness, and you have to treat the drug by itself with the drug in combination, just standard rules of logical thinking about this. And after I published that, I got a lot of pushback, surprisingly, for what I would consider to be irrational reasons. And then it became clear that the whole point of representing an outpatient drug on the basis of inpatient evidence was more than sloppiness or irrationality. It was clear that it was a campaign to discredit the drug for some other reasons that were not being stated by any of the parties who were making these statements against the drug, that this was anecdotal evidence, that this was not randomized evidence, all these claims that were essentially irrelevant to the actual data of the studies available at the time were there because of other reasons rather than objective criticisms of the science. So that's what I got into at the beginning of the epidemic last April, May, June, and have continued to be involved and followed up all the evidence as it's accumulated.
I see. Well, thank you for that wonderful opening that tells us a lot of the setup for what's gone on over the past year and a half with our experience, as physicians and as patients, with regard to, people getting the illness. And for me, COVID-19 is sort of a spectrum. It can be anywhere from asymptomatic to a cold, to, as you pointed out, flu-like symptoms, to pneumonia, to adult respiratory distress syndrome, or God forbid, blood clots. I mean, so it's sort of a whole spectrum of things depending on, multiple factors, how much you get infected with, how ready your body is to be able to fight or not to be able to fight, what your blood type is. Even I'm convinced that AB positives, get hit harder than O's. I mean, that's been my experience and some of the papers that I've read as well. Can we talk a little bit about prevention? And you had mentioned hydroxychloroquine, and for a while, we would have been thrown off YouTube or kicked off of Twitter for even suggesting that something so ridiculous might work. My experience has been good with the drug, not just taking it as a patient when I had COVID, but also to prescribe to patients along with zinc and other things like part of the Zelenko protocol with azithromycin. Can you talk about it and other things in terms of prevention? Because you have some potentially good points to make with regard to, could we have done much better had we distributed hydroxychloroquine and zinc or ivermectin to people in little either emergency packs, or potentially given them like a weekly dose like you do with malaria and hydroxychloroquine?
So this is actually an interesting and subtle question. We know how well hydroxychloroquine plus zinc plus vitamin D plus antibiotics plus aspirin plus other parts of the recipe work for treating outpatients early. And there's been now 9 studies that have looked at that, including national studies in Saudi Arabia and in Iran with tens of thousands of patients, showing how much it cuts the mortality by almost 5-fold, 4 to 5-fold. So we know it works in early treatment. There's no question that science is clear on that. Question about prevention has actually been addressed in India. There are 10 studies now that have been done in Indian healthcare workers. And the net results of that is that hydroxychloroquine used weekly, it's recommended by the India Council on Medical Research, the ICMR, that this should be a prevention, a prophylactic measure taken by healthcare workers. So that their recipe is 400 milligrams of hydroxychloroquine once per week. And the studies there show that the people who take it have approximately 50% cut in risk of getting infected. But what's more than that is that the studies that had looked at how long people took the hydroxychloroquine show that it takes about 6 weeks of weekly usage before the benefit really kicks in, that the benefit is about 80% reduction in risk of infection after 6 weeks. And there's 4 studies showing what we call dose response, that the more weeks that you take the medication, the lower your risk of getting infected is. This is all contributory to reasoning about, is there a causal relationship between taking hydroxychloroquine and reduced risk of getting COVID in these healthcare workers? Now, part of the problem in those studies is that they were taking the hydroxychloroquine while they were exposed to the virus. And so what happens is you see that in the first 2 or 3 weeks that people are actually at increased risk, if anything, of getting infected if they've only taken hydroxychloroquine for a week or 2 or 3. And that's because they quit. That if you start taking hydroxychloroquine weekly and then you get infected, you figure, what's the point of continuing to take it? I've already got it. So they stop. And so the people who took hydroxychloroquine in these studies for only 2 or 3 weeks were ones who are more likely to get sick. So there's a bias in these studies because what should have been done is the full dosage been delivered before the exposure started. However, this was a real world experience and nevertheless shows that after about 6 weeks of exposure of a cumulative dose of about 2.4 grams of hydroxychloroquine over those 6 weeks, that the full benefit of that prevention occurs, and the 80% benefit is comparable to what might expect for vaccine benefit. Now, the subtlety of this is slightly different. If you have a whole population that you're putting on prevention like this, basically, as long as you stay on this prevention, you're cutting the infection by 75, 80%, which is good for the people who need to have their risks reduced. But we don't know if they're able to generate herd immunity while they're on this. And so the question is this good for your society if you're putting everybody on prevention? And the answer to that is nobody knows because nobody studied this. It's a theoretical idea. And it may very well be better to let young, healthy people actually get infected and treat them and develop immunity and very strong immunity from natural infection in people who we know are going to do well. These are people under age 60 with no comorbidities, not obese, no diabetes, and so on. Those people we know do well on average with fighting off the infection, even without treatment. And we agree that probably everybody should be treated if they're substantially ill, even in those people. But the idea is to treat them, let them get infected and treat them, and develop natural immunity. That natural immunity is at least as strong as vaccine immunity. So the question is, how much would you want to give prevention medications to a whole population if we don't know whether they develop immunity by that? And
right,
that's
certainly.
a question.
That's an excellent question that remains to be answered. You know, it would seem that if you're taking the prevention, it might prevent you from getting the infection altogether. However, it may also attenuate the symptoms, you know, kind of like the vaccine is claimed to, with regard to just developing like a cold-like syndrome as opposed to getting a severe pneumonia or worse, certainly. And it would stand to reason, but it would be important, of course, that we had data to pull that out so that we could, you know, point at data, because I know that it's been difficult lately in science. That is to say that science and natural immunity have kind of been kicked to the curb by the general media, by politicians for whatever their reasons are, as well as, you know, academia. I mean, we've had 100 years of learning about our immune systems, and mother epidemiologists that had their kids with certain viral infections get together with other kids so that they would all get them out of the way and generate antibodies. And that may have been, you know, in the early part of your times, Dr. Risch.
Well, it's true. We know that that's an effective method and safe method in general, as long as you got a backup for people who, you know, infrequent people who might not do well. You have a backup for managing it, then that's a safe approach. It really, one wonders that people who are on long-term prevention with hydroxychloroquine, or ivermectin is another medicine that can be used for prevention of getting infected with COVID. How long are you going to stay on the medications? If this illness, this virus becomes endemic in the population, even at a low level, how are people going to manage their long-term risks? Are those people still going to decide to get vaccinated at some later time when the vaccines have more evidence for their pros and cons, when there's other vaccines that are available, the non-genetic vaccines that are in development now that are likely to come out in the next 6 months to a year?
Like more typical vaccines, because the current crop of mRNA and DNA are being called vaccines in the lay media. However, technically, they're more genetic interventions because they force our body, they give it instructions so that we make that foreign T spike protein, which causes all the inflammation, according to research to this point, of the virus.
It's true that the mechanism is one where our cells make the protein antigens for the antibodies to be developed against, rather than the vaccine itself. The problem with that is not that it uses a genetic mechanism necessarily, but that the amount of that antigen, the spike protein that's made by our cells, is uncalibrated. Some people could make a little and some people could make a lot. We know that the lipid nanoparticles of the so-called vaccine travel throughout the body. They get into organs all over the body, including the lining of the blood vessels, that they make their antigens in all these organs all over the body, and not just in the muscle where they're injected or in the lymph nodes draining that muscle. And so we don't really have a good handle on the amount of the spike protein and where it's at throughout the body that can be doing diverse kinds of toxic behaviors, either in small amounts because it's not made very much, or in larger amounts because the cells just do what they do without any regulation.
I have a question. That's great. That's got me thinking that not only don't you know potentially how much someone is going to make based on any amount of a unitized amount of mRNA or DNA instruction, because different people make different amounts, even based on the same amount. That's a great observation. What about how long that's made? Could it be days? Could it be 2 weeks? I've seen some studies that have said it's 2 weeks. Could it be longer? I mean, a wider or more broad exposure for a longer period of time certainly would be more concerning than a lesser exposure for a shorter period of time, I would imagine.
So I don't think it's well known. Pfizer, one of the manufacturers, did an animal pharmacology study that was submitted to the Japanese regulators, and I believe it took an FOIA request to make this more publicly available. It shows all of the organs that that vaccine-like particles travel to. It shows that they accumulate in tissues like the spleen, like the ovaries, over 48 hours, that they're still there in substantial presence. After 48 hours was the length of time in the animal model that they used. So presumably it's going to be well more than 2 or 3 days that this is, accumulating in those organs, and we don't really know how long the genetic machinery is functioning, but we know that the particles themselves are around for at least 48 hours.
Wow. So we don't know what dose is being made by the body, and we kind of have an idea of the minimum of all of that, but we don't know what the maximum is, and that, is surprising because it's not a typical vaccine where you get a particle of the protein coat of whatever the beast is, or you get an inactivated one or attenuated in some way or killed. And then your body just reacts to the dead stuff like it were live. But at that point, it's no threat really, because your body clears it rather rapidly. So we don't have a lot of information of how this is cleared, which is of concern.
Well,
So,
that's the point, that we don't have a lot of information, that we know that empirically it's safe for most people, that people do have localized adverse events, discomfort and pain and maybe some fever and so on, that go away. We also know that in the 2 weeks after each of these vaccinations, that people are at about threefold increased risk of either getting COVID, expressing COVID that they had but were able to suppress, and even the mortality risks are increased over 2 weeks after each dose. And this has been seen in 80 countries across the world, that in the 2 weeks after each vaccination, that the mortality rates go up transiently and then they go back down. After 2 weeks, when the vaccines really start doing what they're supposed to do, then you see the benefit of reduced infection in them. So you have to get through. So people don't know that they need to quarantine themselves for 2 weeks after each vaccination to prevent them from getting COVID or respiratory illness or whatever it is that actually transpires during the time when their immune system is struggling against the vaccines for that 2 weeks.
And I wonder, is that what happened in Israel? Because Israel kind of went through their population immunizing everybody, but then had this colossal spike in their disease. Would it be potentially relatable to the phenomena you're speaking about, that they would be more sensitive to the disease over the first 2 weeks and then less later?
It might be. It's hard to tell because Israel also came off of a lockdown at about the same time. So it's really hard to separate out the different components of the behavior of the case numbers and the deaths from all of that. I think that there's pretty clear evidence from so many countries that when the rollouts of the vaccines occur, you see this bump. The case numbers and the mortality goes up a bit, then it goes back down after that. So it's pretty clear that this is going on. It is transient. I'm not speaking against the vaccines in general. I think they are largely safe, but there are plenty of people now who are having adverse events, and in particular systemic ones, such as in clotting and bleeding issues, neurologic issues, and so on. In young people, myocarditis, this is a cardiac inflammation issue that is infrequent, but is still happening. And these are things.
Pregnant women?
Pregnant women, we just don't even know. Because pregnant women vaccinated in the first trimester of pregnancy have not been followed long enough to know what their birth outcomes are. So we don't even know the status of what's been done. They were not part of the trials, the randomized trials in the first place that the manufacturers did. Nor were people with previous COVID, and then vaccinated. So in fact, there are now 4 studies that show people who've already had COVID and recovered have increased risk of moderate to perhaps more than moderate adverse events from the vaccines. And we already know that they're already essentially immune. They have as much immunity as vaccination. And so we don't know that there's any additional benefit that they've gained from taking the vaccines over their natural immunity. And so it's the risk benefit equation for them is more in the favor of not taking the vaccines.
So it's a balance, and it's, individualized, like everything else in medicine. But unfortunately, the government, media, and big business are trying to make it a needle in every arm, as they were saying in Texas, which I think is a bit scary. They're having lotteries to get people to do it now, and they're threatening you have to wear a mask unless you do this intervention, even if you have, like you said, a relatively low risk for significant disease, or are at risk for getting really sick from these if you've had COVID in the past, or you have a bleeding or clotting issue, or you're pregnant, and it's really hard to say. So Dr. Risch, this is a good point to ask a question with regard to herd immunity. In the last 100 years, herd immunity usually had to do with naturally acquired immunity, that is antibodies, natural killer cells, B cells, T cells, and all the wonderful things we have in our immune system. And over the last 60 years, 70 years, we've started bringing in vaccines of different types. And this is a whole new vaccine, as we were talking about. In fact, it's sort of more of an intervention than that. It's a new way of doing business technologically. So what are your thoughts on, herd immunity and natural immunity and vaccine immunity? Because they may differ.
People have a misunderstanding about what herd immunity is. Herd immunity occurs when you reach the top of the epidemic curve. So epidemic curves, it goes up exponentially, and then it slows down and reaches a peak, and it turns over from the peak and then goes back down. And that's the simplest form of it. When it gets to the peak, you're at herd immunity. That means that each person who's infected infects fewer than one other person after that. So the infection dies out over time. That's herd immunity. Herd immunity by itself is not enough in order to make the population safe. There's a difference between getting rid of the infection altogether and herd immunity. Herd immunity is when that process starts of getting rid of the infection, but we want much more than herd immunity. So we know that herd immunity in this case occurred in the United States, largely in many states, if not most, in September, October of last year. we're well past the peak. By December, in most of those states, we're well past the peak of the infection curves. Most of them were already down in a major way. This occurred in the United States when the case counts in the states were at the level of 100,000 cases per million population. And if you look at any of the data sources, you'll see that when that happened, that these infection curves were dramatically down. Now, that doesn't mean they were at zero. There's still cases occurring. There's still deaths occurring. We want to get it down as fast as possible. Vaccination contributes to that. The curves have gone down faster, and in places with less herd immunity have gone down more dramatically after the vaccination has added to it. So now we know in places like North Dakota, South Dakota, Rhode Island, Arizona, Tennessee, other places, that they have 80 to 85% immunity, at least. The combination of herd immunity plus vaccination immunity together is at least 80 to 85%. That's what's driving the infection away. And that's what we need, is to maximize that as best we can. The herd immunity is actually responsible for the majority. So we don't need to vaccinate everybody. Vaccinating half the population is probably enough to get to 80 to 85% immunity across the population as a whole.
And when you said vaccination, sorry to interrupt, when you said vaccination earlier in the program, you had mentioned that, it was somewhat nuanced, that it was seniors like over the age of 70 that would be most beneficial, people living in nursing homes, perhaps people with concomitant other illnesses or risk factors that might increase their risk of having a problem with COVID-19 or SARS-CoV-2. So certainly there's really no call to vaccinate everybody of every age every year in ad infinitum.
No, in fact, children, unless they have obesity or diabetes or some chronic condition where they're actually at risk of having a severe response to COVID infection, should not be vaccinated. There's no reason to vaccinate them. For children, they get this as maybe a fever, tiredness, weakness. That's about the extent of the disease in children. Children do not transmit this illness by and large to adults. They get it from adults. There's lots of evidence for that. And so there's no reason by and large to vaccinate children. The deaths that have occurred over the whole last year in children from COVID have been about 400 deaths either from COVID or with COVID, compared to the 500,000 or 600,000 Americans who've died as a whole. So it does occur in children, but it's at the level of flu, in past flu seasons. So this is not the worry. Children don't need it by and large. And so we need to concentrate the risk benefit on the people who have sufficient risk that there's a benefit for them in getting vaccinated. And this is, as you said, older people, obese people with comorbidities, people who won't do well. Those are the people to concentrate vaccination on.
Great. Well, I appreciate that information. And we could probably talk for the whole hour and then perhaps a few more, nuancing and trickling. I wanted to get more information on you, your contact information, your practice, anything that you've published, and places people could go for more information on this topic as it emerges.
So if you Google me, my last name, Risch, R-I-S-C-H, and Yale, you'll find my homepage. You'll find my email address. You can contact me that way. That's the best way. There's a lot of resources now. Off the top of my head, I think the AAPS has, if you Google AAPS, you'll come up with their website. They have guides to this. The Economic Standard Journal webpage has discussions of COVID and its outpatient treatment. Dr. Peter McCullough has published a couple of papers on this. If you Google his name, you'll come up with those papers with the recipes for treatment and so on. There's a lot of discussion about this on the internet, still standing uncensored at this point.
Still standing and uncensored. In fact, some of it's been restored.
Oh, that's good to know.
Yeah, as the algorithms for discrimination change, some of them have been allowed to stand or been restored. So I appreciate that thorough list. That AAPS organization is the Association of American Physicians and Surgeons at aapsonline.org. of course, Dr. Peter McCullough down in Texas is another great one. And it's great to follow you. I mean, it's great to see you and hear you both on audio media and video media. And thank you for spending time with us today and working tirelessly to help people understand what's really going on and what they really can do, and what individuals should know about this to make decisions for their own bodies.
Pleasure. Glad to be with you.
Thank you. For this and more information, you can go to the website healthisnumber1.com. On the links page, there's a COVID-19 links that are very useful to some of Dr. Risch's work, some of Dr. McCullough's work, and some of the organizations that were referred to. Thank you again for being with us for this time. Hope it's been enlightening. Feel free to leave comments below and please subscribe. Look forward to seeing you again soon with more great information and another excellent expert. Thanks again. Be well. Here's your fist bump. You can also follow on Twitter at the @ Dr. Craig Wax, DrCraigWax. And for all kinds of health stuff, diet, exercise, and other healthy lifestyle information, same thing on Instagram at the @ Dr. Craig Wax.